Good evening to all the aspirants present here. Today's topic is acute coronary care. It is class 3, and the speaker that we have here is Dr. Sangshaptak Saha. He is an associate consultant critical care medicine at Apollo Hospital, Kolkata. Thank you, sir. So you may take over.
Yeah. Acute coronary care part, and today, as I discussed in the last class, that it will be basically a practice session for the MCQs, solely based upon cardiology. In the first class, we discussed about acute coronary care, the AMI part, and the acute coronary block, those things. And we discussed the two MCQs and mostly two ECGs at the end of the class. The second class is more focused on pericarditis, myocarditis, and cardiomyopathy. So today we shall be discussing mostly about cardiology in the MCQs. I shall be sharing around 25 MCQs, and one of you is answered, and then we shall discuss about it. So I will be sharing this screen, and for each one of you answer and read out the question and answer. Then we shall discuss about it for a few minutes, and we can move on to the next question. Somebody can volunteer and answer. Details on chat box. Okay. So is anybody volunteering to answer or?
Most.
Yeah. So 76 years old woman was in the acute medicine follow-up clinic. She has been admitted with palpitations, but at the time of admission, her respiratory discipline showed normal sinus rhythm. So she had these episodes a few times also before, but they always reverted spontaneously. Significant past medical history was not present. An outpatient 24-hour ECG was performed which showed 10-minute turn of air. The patient did not feel palpitations at this time. So what is the first thing management? So basically an arrhythmia patient who had previously also had similar episodes. Now she is having a 10-minute turn of air and the patient did not feel palpitations at this time however. So it was asymptomatic. So what will be the first thing of management? So there are 5 options. So if one of you can answer that, let's try to answer and we will discuss about the correct answer. Okay.
All the aspirants are requested to kindly unmute the mic and please uh, do initiate in the class.
Yeah, because then it will be an interactive class. Otherwise, like, I can also share the answer and discuss. Okay, first one I shall discuss and maybe others will join in the next one.
Please take an initiative. It's an interactive Q&A session. It is a helpful session for all. Thank you.
So basically, this is a patient of who is suffering from atrial fibrillation, and previously she had this atrial fibrillation terminated spontaneously. So those were autosomal intermittent because the spontaneous terminated within 48 hours, right? So that is the typical definition. That is the classical definition classification of atrial fibrillation. So that happened, and now the AF is occurring. But we do not know why the AF is occurring or what is the underlying cause of the AF. So because that much information is not being given. So the first option, no treatment is necessary as the AF is short and self-terminating, is not possible here because she is having this recurrent ache. So the first option is not the answer. The second option is fill in the pocket thickeners. Fill in the pocket thickeners is the chronic conditions in which the patient is like the patient is having a continuous ache which was not terminated, or the patient will be chronic ache and we know that it will not be it will not be terminated by the classical medication. Then it usually apply. It is not for the ICU patient, so very unlikely that will be the answer in the in the EDIC exam, and it is not the answer here. The third is regular amiodarone. Regular amiodarone is for persistent ache where the patient is symptomatic. Here the patient did not feel palpitation at this time. That is also not the answer. And regular deoxin also is not a first line management drug. As we know, in a 76 years old woman, the first line management will be rate control versus rhythm control. Here, the patient does not have chronic ache, so unlike the persistent ache. So rhythm control is not the question here. Here the main goal is rate control. So we have to go for a rate controlling drug. Which is first line is either a beta blocker or a calcium blocker. So the answer here is a beta blocker. So in this one question, they are testing your knowledge about the classification articulation, the basic management articulation, also whether you know when we are using amiodarone, deoxin, and thickenite. So only after this much knowledge you can go for the option D, regular beta adrenergic blocker. So AF is all like everybody knows that they'll practice 50 questions based on AF, so you know everything about AF. Okay. So this is the first question. So now we shall become the next question, and I want somebody to read the question first, and then I want to answer. It's not an exam, right? So even if you're wrong, then also it does not matter. You can just analyze how you are approaching the question and going for the answer, and then you can take up the explanation after that. I will give you 2 minutes to read the question and then to get the answer. So, students, have you read the question and like if somebody ready to answer this? So, what are the like persistent points for this question? So, firstly, the patient is a hypertensive patient with ischemic heart disease and had a previous history of myocardial ischemia for which a PTCA has been done, right? This time he has presented with ventricular tachycardia, which was hemodynamically unstable. So hemodynamically unstable ventricular tachycardia and management for that has been given already. So that is not a part of the question. Here undergone DC cardioversion and now he is in sinus rhythm. Troponin T was raised and it was rising after 12 hours. So there is a cardiomyopathy because of the VT probably. And echocardiogram shows a LPF with a low ejection fraction, and there is also like an anterior hypokinesia. So, what will be the management option for this patient in long term? So, they have asked for a long term management strategy, not a short term management strategy, right? So, long term, what is the management option? Okay, so like you were answering here, so it's option A. Dr. Muhammad and Dr. Dharani has told that it's answer A. Okay. So it's referred to inpatient implantable cardiovascular defibrillator. So that is the answer. So first I shall discuss the other option, and then we can go back to that. So second option is referred for inpatient electrophysiology testing and ablation of VT. So that is not the answer here because the patient needs a long-term ICD. Electrophysiology testing ablation of VT can also be done, but like the VT has already been terminated here, so that is not the answer here. The third option is inpatient PTCA. So troponin T raising here is because of the post-VT patient. So rise in troponin T is not specific for acute myocardial infarction. It can happen post-VT and the post-shock. So we have to have the information and rule out option C. It is not an AMI. Option D is referred to the cardiology outpatient department for assessment. So again, that is a vague option, and like common sense answer that will not be the answer here. And option E is long-term amiodarone. Long-term amiodarone is chemical cardioversion. Chemical cardioversion is not the answer here because ICT has got long-term mortality benefits, which like better outcome than amiodarone. That is why we are going with the option A here. Somebody is confused with what is the option here. Option like question of previous question. So here the answer is regular beta adrenergic blocker because the patient needs a rate control care, and then we have to analyze the patient, further test the patients, and then we can go for the amiodarone or the dioxin or chikunite. Not right now because that much information has not been provided here. So the option D is the answer. Okay. So this is the third question. This is showing the ECG. So 34-year-old woman presented with palpitations. Recently, she has been posted for ablation and she has been viewed by the electrophysiologist. She had tried the crossover maneuver, did not work. Vehicle maneuvers, no effect. Heart rate 200, blood pressure is stable. So she is not hemodynamically unstable as of now. This is the ECG. Analyze the ECG, and then I can show you the options and we shall discuss. Okay. I think the ECG was is a straightforward diagnosis. Can somebody tell me what is the diagnosis on the basis of the ECG? Write it on the chat box. While I share the options. So, okay, doctor. Her name is Dr. Neji, NEH. You have written that the answer is what have you written? You have written that the answer is PSBT. PSBT and treatment is adenosine 6 milligram. Why do you think the answer is PSBT?